Hello everyone, welcome to Resident Not 7. Today we are going to start our INICET classes and we will start with atrial fibrillation. So atrial fibrillation is an arrhythmia, which is the most common arrhythmia and its prevalence increases with age. Hence it is an arrhythmia of old age. The prevalence of atrial fibrillation in the whole world is about 0.51% and in India it is about 0.19%. So coming to the definition of atrial fibrillation, according to the European Society of Cardiology, it's a supraventricular tachyarrhythmia with uncoordinated atrial electrical activation with constitutively ineffective atrial contraction. So the atrial fibrillation is an tachyarrhythmia where heart rate is generally more than 100 per minute and it is characterized by irregular atrial electrical activation. This irregular atrial activation is also characterized by ineffective atrial contraction. Hence, ineffective atrial contraction leads to poor atrial contraction and there will be stages of blood in the atrium during the atrial systole. So, atrial fibrillation should always be proven by ECG and the rhythm should be having irregular RR interval, absence of clearly discernible P wave, and the rhythm should be persistent for at least 30 seconds in a single lead ECG. So, coming to the mechanism, here sinus rhythm is present, a clearly discernible P wave is present, and the RR intervals are regular. So, this constitutes what is called as sinus rhythm. Coming to atrial fibrillation, it is characterized by irregular RR interval, and there is no clearly discernible P wave. These waves are called as fibrillatory waves or F waves. So this is the ECG of atrial fibrillation, where irregular RR intervals are present, along with fibrillatory waves, and there are no clearly discernible T waves. And another arrhythmia, that is tachyarrhythmia, which is very similar to atrial fibrillation, is atrial flutter. This is also an atrial tachyarrhythmia, but this is differentiated by regular RR interval and characteristic presence of flutter waves. These flutter waves are all similar in morphology because they happen due to a single macro reentrant circuit. This circuit is also called as KO tricuspid isthmus. That is the junction between the inferior vena cava and the tricuspid valve. So this is the KO tricuspid isthmus, this is the IVC, and this is the tricuspid valve. So the isthmus in between the IVC and the tricuspid valve and the reentrant arrhythmia travels from the supracrustal terminalis and it goes to the KO tricuspid isthmus, tricuspid valve, AV node, atrial septum, SA node, and again crista terminalis. So this is the way by which normal orthodromic atrial flutter is formed. So this is a reentrant arrhythmia. So coming to the topic proper atrial fibrillation, this characterized into paroxysmal, persistent, long-standing, persistent, and permanent. If it terminates within 7 days, it is paroxysmal. If it is present for more than 7 days, it is persistent. If it is persistent for more than 1 year, it is long-standing, persistent. Permanent atrial fibrillation. For example, if a patient is having heart failure and is LA, LV, RA, RV, all are dilated. So this leads to a dilated heart and an increase in dimensions of the heart. So this forms a substrate for re-entry, increased chances for re-entry. Hence, in these patients, even if we try to revert the rhythm from atrial fibrillation to sinus rhythm, there is an increased chances of reverting back into atrial fibrillation. Hence, there is no use in cardioverting these patients into sinus rhythm. Hence, in these patients, only rate control is will be done and rhythm control is being avoided. So this is a therapeutic decision. Coming to the mechanism of atrial fibrillation, before going to that, for any tachyarrhythmia to happen, there are three mechanisms. One is triggered activity, two is enhanced automaticity, where another pacemaker takes over the SI mode, and three is re-entry. For atrial fibrillation, the enhanced automaticity is due to the chaotic rhythms which are arising from the pulmonary vein. And the enhanced automatic rhythms, that is enhanced automatic irregular rhythms, which are arising in and around the pulmonary veins, are being maintained by the micro re-entry circuits in the atrium. So these two contribute to the formation of atrial fibrillation. So atrial fibrillation is an arrhythmia where enhanced automaticity and re-entry are responsible for the initiation and maintenance of the tachyarrhythmia. So multiple re-entry wavelets as the rapidly discharging autonomic foci in the pulmonary vein contribute to the development of atrial fibrillation. So as I told, rapidly focal firing in the pulmonary veins are responsible for initiation of atrial fibrillation. Cause of atrial fibrillation. Any cardiac disease can cause atrial fibrillation. Any pulmonary disease, hyperthyroidism, CKD, alcohol, cocaine, hypokalemia, and hypomagnesemia. So the common symptoms include palpitations, fatigue, dyspnea, effort intolerance, and lightheadedness. These patients usually don't present with syncope, since 80% of the cardiac output, that is the LV filling, happens happens even before the atrial systole. That is happens before the protodiastole and the early diastolic period, where atrial contraction is not happening. Only 20% of the ventricular filling is happening by atrial systole. Hence, syncope is a very, very rare feature. So coming to the clinical features, these patients could also be asymptomatic. In asymptomatic patients or minimally asymptomatic patients, even though they are not symptomatic, they are at increased risk of stroke. Why? As I already told, atrial fibrillation is a chaotic, irregular tachyarrhythmia, and there will be very, very irregular and ineffective atrial contraction. This ineffective atrial contraction will lead to stasis of blood in LA as well as RA. The stasis of blood in LA, particularly LA appendage, leads to formation of clot. This clot can break any time and go into the brain and can cause stroke. Hence, these patients are increased risk of cardioembolic stroke even though they are asymptomatic. And another thing, these patients are also at risk for development of heart failure. Why? Any tachyarrhythmia over a long period of time, if it is sustained, can lead to tachycardia-induced LV dysfunction. This can lead to a condition called TIC, which can also be named as AIC. So coming to the physical examination, these patients will have irregular pulse, which is a clinical hallmark, variable intensity of S1, and apex pulse deficit. What is apex pulse deficit? It is a clinical finding. You need two persons. One person to calculate the radial pulse, and one person with a stethoscope to calculate the heartbeat per minute. If the difference in the pulse rate calculated by auscultation and palpation is different by more than 10, it is characteristic of atrial fibrillation. Okay, what is the mechanism behind this? As I already told, atrial fibrillation is an irregular tachyarrhythmia. So the RR interval, which is shortest, this RR interval is shortest, but this RR interval is the long. So the RR interval, which is shortest, means there will be low period of diastole. So the lower the diastole, the lower the LV filling. So the lower the LV filling, the lower the ejection stroke volume. So the low stroke volume leads to absence of pulse. I hope you understand. So consequences, they already told there are increased risk of stroke, there are increased risk of dementia because of the increased microthromboembolic events. An uncontrolled ventricular rate, as I told, over a long period of time can lead to LV dysfunction, congestive cardiac failure. So for diagnosis, we need to lead ECG. And for atrial fibrillation, treatable causes include, as I already told, hyperthyroidism, so you have to do TSH, hypokalemia and hypomagnesemia, CKD to test serum creatinine, as well as any structural heart disease. Hence, you should do 2D. For example, mitral stent. So management of AF, either you have to control the rate of AF or you have to cardiovert the patient into sinus rhythm, decrease heart rate. And as I already told, these patients are increased at risk of stroke. We have to anticoagulate them. So for anticoagulation, there are certain criteria and score. That score is called a Chatsworth score. We will come to that later. So before that, we will see how to cardiovert and whom to cardiovert. Suppose a 60-year-old male admitted for UTI sepsis. He has normal sinus rhythm, but in hospital he develops atrial fibrillation. His vitals are stable. What he will do? These kind of patients we can cardiovert. How you will cardiovert? Since the patient's vitals are stable, there is no routine usage for DC shock. We can try drugs. So the common drugs which we use, everybody knows that, which is amide. So suppose this patient is having atrial fibrillation, but BP is less than 90/60. What he will do? So these patients we have to stop. I hope you understand. So for a stable patient, we have to do pharmacological cardioversion via amidrone. For an unstable patient, we can directly shock the patient. Remember, this is for non-valvular AFib. Valvular AFib particularly happens in mitral stenosis. In mitral stenosis, these patients could be having enlarged LA size. And enlarged LA size means even though you cardiovert this patient, there is increased risk of recurrence. Hence, most of the patients of mitral stenosis with atrial fibrillation, there is valvular atrial fibrillation, we always prefer rate control than rhythm control. So coming to the rhythm control drugs, we all have flecainide propafenone class 1C, vernacular sodium plus potassium channel blocker, atrial specific, and amiodarone class 3, and abitulate. So amiodarone is a drug which is preferred for structural heart disease. Remember that. And flecainide and propafenone can be used as oral drugs, particularly in OPD settings, but it should be avoided in structural and ischemic heart disease. How to use amiodarone? You have to give 300 mg IV stat in 100 ml NS for 1 hour. This should be followed by 1 mg per minute of infusion for 6 hours and 0.5 mg per minute for 18 hours. And the total loading dose should be 10 grams. Hence, in the initial 1 week, we have to give 400 mg TDS for 1 week. This will amount to 10 grams. This should be followed by 100 mg OD at BD for maintenance. The brand name available is Cardaron. So, rhythm control and anticoagulation. Now we are coming to anticoagulation. So, now we are seeing only non-valvular AFib. So, patient develops atrial fibrillation and he comes within 48 hours. Since 48 hours is a short time, there is low risk of stroke. We can directly cardiovert this patient, and post cardioversion, we have to anticoagulate for root cause. Why after cardioversion, as the patient, since we have cardioverted, then anyway the patient has gone to sinus rhythm. So why we have to again anticoagulate for 4 weeks? Even though we are converting atrial fibrillation into sinus rhythm, the atrium will be in a state of standstill. It won't contract effectively for the next 4 weeks. So we have to anticoagulate these patients for 4 weeks, and particularly the risk of stroke is high for the first 2 days post cardioversion. Suppose the patient is coming after 48 hours or you don't know the duration. For all these patients, you have to do TEE. Do TEE and find if any thrombus or embo is there or not in the LA. If thrombus is present in the LA, we have to anticoagulate for 3 weeks, then cardio over this patient. As I already told, post cardioversion, routinely have to anticoagulate for 4 weeks. Suppose there is no clot in the LA or LV or RA, we can cardio over this patient directly and anticoagulate for 4 weeks. So, so now we have now we have done TEE. There was no thrombus. We have anticoagulated cardioverted the patient and anticoagulated for 4 weeks. Now what? After 4 weeks of anticoagulation, we have to calculate the stroke risk. If the by the score called Chadwas score. If Chadwas score the criteria fits, we have to anticoagulate these patients for lifetime. And if the score is less and the criteria is not fitting, then no need to anticoagulate for lifetime. So basically, we have to calculate future thrombotic risk. So this is the Chadwas score. It's a very, very important question. It consists of congestive heart failure, H for hypertension, A for age more than 75 years, D for diabetes mellitus, S for stroke, previous stroke, PA or thromboembolism, V for vascular disease, A for age 65 to 74 years, and sex category male. Males have more risk than females. So the total score is 9. We have to initiate anticoagulation if score is more than or equal to 2 in males and 3 in females. This is a class 1 indication. So it has a benefit. So score of 2 in males and score of 3 in females, a definite indication for starting anticoagulation in non-valvular AFib. After you have finished the 4 weeks anticoagulation, after cardioversion, you have to calculate the risk for future thrombotic risk, and then you have to initiate anticoagulation based on the chat was. So this is the score called as the score. The score has nothing to do with denying anticoagulation. It just tells you the bleeding risk. If score of more than 3 is present, then these patients are at increased risk of bleeding. So you have to be more careful while initiating the antithrombotic agents. But this has nothing to do with stopping or denying your anticoagulation. So this just assesses the risk and tells you to be more careful and you have to advise the patient regarding it. So what are the common oral anticoagulation? Warfarin. In government setup, we usually prefer warfarin. We start at 5 mg or 2.5 mg OD at 5 p.m. Dabigatran, rivaroxaban, apixaban, and doxaban are all novel oral acting anticoagulations, and these are absolutely contraindicated in valvular AFib because there are no evidence, and it is particularly increased. So now till now we have seen acute non-valvular AFib in a sick patient. Now a patient comes to an OPD, a 30-year-old male. He is having atrial fibrillation and he is stable, BP is stable, vitals are stable, no symptoms. What do you do? You can just give oral drugs, as I already told, flecainide and propafenone. Flecainide doses of 200 mg and oral propafenone dose of 300 mg. And we have to take the repeat ECG, and mostly within a day, the rhythm will be converted into sinus rhythm. Usually, these patients are also converted. These patients are also given beta blockers along with antiarrhythmic. Why? Since atrial fibrillation can get converted into atrial flutter, there is always a risk of 1%. So we have to control. If suppose patient develops atrial flutter on giving this antiarrhythmic drugs, atrial flutter has a rate of 300 per minute. At this rate, if it goes to ventricle, patient will soon develop hemodynamic compromise. So we have to always give beta blocker, considering the risk of development of atrial flutter. It should be given 30 minutes prior to the routine antiarrhythmic drug. So this strategy is also called as fill in the pocket strategy. So coming to rate control. Rate control is usually done in patients in whom we are not rhythm control is not successful, or the LA or RA dimensions are so large that further cardioverting these patients has no benefit. So for these patients, the ideal rate is less than 110 per minute. Goal of rate control, decrease the rate of 110 per minute. By decreasing the heart rate, you can prolong the diastole. So increasing diastole will increase LV filling and further increase the stroke volume and decrease the symptom of the patient. Also controlling the rate will decrease the risk of TIC, tachycardia-induced cardiomyopathy. So the rate control commonly used drugs are metoprolol, which can be given as IV or oral, IV in acute settings, and we can change into oral. Usually metoprolol XL can be used starting at dose of 12.5 BD, and we can up titrate it to a maximum of 400 mg OD. So digoxin is also a drug particularly useful if patient is having low EF. We can give digoxin as a rate control drug also. So factors considering rhythm control. In whom we have to consider rhythm control. As I already told, if patient develops heart failure and heart dimensions are increased, there is no use of it. So in acute paroxysmal AF with no structural heart disease, we can consider rhythm control. In inpatients, we can consider rhythm control. And if heart rate is difficult to control by rate control alone, we can use. As well as any acute illness precipitating, we can consider rhythm control. So I have seen rhythm control, we have seen rate control, we have seen how to anticoagulate patients. Now we have to see other forms of therapy, and one form of therapy is catheter ablation. By going via the right femoral vein up to the right atrium and via transeptal puncture, we can go into the left atrium. We can go to the pulmonary vein and we can give, via radio frequency or via cryoablation, we can ablate and we can isolate the pulmonary vein from the rest of the atrium, thereby preventing the enhanced automatic signals coming from the PV into the atrium. So this is electrically isolating the left atrial regions around pulmonary vein opening. So this is particularly done for patients who are having paroxysmal AF and in whom sinus rhythm has been maintained for more than 1 year. These patients are mostly responsive to antiarrhythmic drugs. So the catheter ablation is only preferred for in patients whom are having paroxysmal atrial fibrillation and in whom rhythm control is easily achievable. For them only, we are performing this catheter ablation, and it is less effective in patients with persistent atrial fibrillation. So other ablation targets are non-pulmonary profiles. So this is cryoablation balloon via the transfemoral route, via the IVC, right atrium, atrial septal puncture, going to the left atrium, we can go into the pulmonary vein, and via cryo balloon, we can update the pulmonary vein areas. So coming to another condition called Wolff-Parkinson-White syndrome and AF. As we already know, Wolff-Parkinson-White syndrome is a tachyarrhythmia due to a bundle of hint. The signal coming from the SA node, instead of going to the AV node, will directly pass along the bundle of hint and it will go into the ventricle and activity, leading to short PR interval and the formation of delta wave. So what if AF happens in Wolff-Parkinson-White syndrome? The formation of AF, that is, if AF is having a rate of 150 per minute, AF can easily transmit along the bundle of hint and it can lead to formation of ventricular fibrillation. Hence, our role is to block both AV node and bundle of hint, or at least bundle of hint alone. The drugs which are doing these functions are procainamide and ibuprofen. Particularly, procainamide can be used in hemodynamically stable patients. But if you are considering hemodynamically unstable patients, we all know we have to do cardiac pressure. So for Wolff-Parkinson-White syndrome, you have to update the bundle of hint. That is the treatment. And particularly AV nodal blocking agents and digitalis and CCBs are contraindicated because blocking the AV node can easily transmit the signals from SA node across the bundle of Kent into the ventricle, thereby leading to ventricular fibrillation. So non-pharmacological stroke prevention, there are two devices which can occlude the LA. Since LA is the major site for stroke formation, that is thrombus formation, we can decrease the risk of stroke by just occluding the LA. These kind of devices are particularly useful in patients in whom anticoagulation is a contraindication. So the device is called as Watchman device. The trial which tested the device called Protect AF trial. This is the Watchman closure device. It goes and occludes the left atrial appendage, thereby leading to occlusion of LA and leading to the formation of leading to decreased formation of LA class in AFib. So this is a lariat device where a suture is placed around the LA appendage and it is being tied off. This leads to decreased blood supply to the LA and consequent atrophy of the LA, thereby leading to atrophy of LA appendage and decreased risk of stroke formation. The device is called as lariat device. Remember that. So the usual the